So as Lily said, we're talking about the coordination and collaboration of the psychosocial care team. And this is a picture of our team, not just psychosocial, in Syracuse, New York, which is where I work. I'm excited to be a co-moderator on this team, on this presentation. We started planning this in 2020 for 2021. So this has been 2 years in the making, so this is going to be fantastic because we've had a lot of time to kind of put this together. Even the moderators had the opportunity to change due to role changes, so I'm just excited to have had the opportunity to work with Lily. Most of our speakers have stayed the same with some changes, but it's going to be a great program, and I'm excited to be part of it. So to begin, I just wanted to state that both I do not have any disclosures, and this is Lily's disclosure. So when I was preparing for this session, I had the opportunity to look into when did social workers become part of the cystic fibrosis team. So I reached out to a couple of resources like the Mental Health Advisory Committee as well as the Cystic Fibrosis Foundation. And they were both mystified, both of these resources were mystified because they said, well, social workers have always had a seat at the table. They were part of the cystic fibrosis care team since the 70s. They had a challenging time trying to figure out when social workers started being part of the team. They've always been a vital part, and that was exciting for me to hear. I also added that in 2015 there was the plenary where mental health was addressed from the NACFC with the keynote, with the plenary address, "There is no health without mental health." So I also listed here other members of the psychosocial care team. And then just briefly to review the objectives of this learning group, to describe the CF Psychosocial Care Team as it relates to the multidisciplinary team approach to care, to list at least 3 qualities of a cohesive psychosocial care team and ways to strengthen communication and collaboration among team members, and to differentiate between roles, tasks, and objectives of the psychosocial care team members. And this is a list of our presenters. So without further ado, I'm going to introduce my colleague, Dr. Christina Nicholas, and she is our pediatric psychologist in Syracuse. Thank you.
Too short for this mic initially. Hello, everyone. I'm Dr. Christina Nicholas. I'm a pediatric psychologist at Upstate Golisano Children's in Syracuse, New York. I'm excited to talk to you a little bit today about our psychosocial team there in Syracuse. We are, you might also see SUNY Upstate. We are within the SUNY system, and so I'll talk a little bit more about that. I have no disclosures. So Golisano Children's Hospital, or GCH, is embedded within Upstate Hospital in Syracuse, New York, or SUNY Upstate Medical Center, which is also embedded within the larger SUNY system in New York State, which is our state university system. So we are a piece of the bigger picture there. But we are located in Syracuse, New York, and Syracuse is right in the very, very center of New York State. Anyone from New York City area would call that upstate. We would call it central New York. And so we serve a relatively wide range of patients, or location-wise. We have a relatively large catchment area along the whole entire center of New York State. And so our patients from St. Lawrence County can drive, around 3 hours to get to us. Our patients down in the southern tier in Tioga and Chemung and Broome County, they might drive an hour, hour and a half to get to us. So relatively wide, and for those of you who are familiar with geography, we are right along the edge of Canada too. So those families in St. Lawrence are right on the Canadian border. So they're pretty far away from where we are. We are serving 17 counties total. We have about 120 patients in our pediatric team. And we do have a dedicated pediatric team, though we are co-located with our adult team and have a number of providers who overlap between the two the two teams. That's been really nice, that overlap and our co-location for transition a lot of the time to adult care, so that's been really nice. But I am dedicated to pediatrics, as is our social worker, Kim, over here. And we do have a mental health coordinator who I'll talk about a little bit as well, and she overlaps between the two with slightly different roles between the two. Our providers, our psychosocial providers, are able to provide services inpatient and outpatient. And so our children's hospital, we call it the Treehouse, is located right across the street from our clinic, which is the physician's office building, neither of which are located where our offices are. So we are in 3 different locations at the moment. We'll talk about that a little bit more. But we do have about 4 clinic days per week with any sort of range of cystic fibrosis patients, from 2 to 5 patients a day. No specific rhyme or reason is the day or time when they're scheduled. They kind of just go on a schedule and we all figure it out. Our current team, it's interesting Kim mentioned, like, when did the social workers start in clinics? I tried to track that down in our clinic as well, and there wasn't a whole lot of specific information, but I got a similar answer. We have always had a social worker, is what I was told. So in 1970, our center was founded. There was a social worker present. I suspect there have been multiple social workers since. In fact, I know there's been at least 2. And we had a child life specialist join in 2010. And then we had another psychologist prior to my involvement from about 2011 to 2015. They weren't specific to cystic fibrosis. I think they were more as an as-needed basis at consult. They mostly did behavioral sleep in our pulmonary clinic. So they were kind of involved, but not super involved. Kim, our current social worker, correct me if I'm wrong, joined in June 2015. And we had a mental health coordinator who joined in December 2017. I joined our team in November 2020 in the midst of the COVID world, and we had our child life specialist unfortunately leave for another position, fortunately for her, but unfortunately for us, in January 2020. So there's been some adjustments in how we manage our clinic and our psychosocial team since then as well. So currently, our team has our social worker who is full-time equivalence and does some general pulmonary work as well with our pulmonary clinic. I'm about 0.25 dedicated to CF, and the rest of it is a mix of our general pulmonary patients and inpatient consultation liaison work just generally for our hospital. And then we have a mental health coordinator who about a quarter of her time is dedicated to pediatric cystic fibrosis. The remainder of her time is as the mental health coordinator for the adult center and for social work for the adult center as well. And we did have a child life specialist, like I mentioned, who was 0.8 up until January of this year. We communicate in a huge variety of ways. It kind of depends on exactly what we need to communicate about. So we do communicate in person. I would say this is relatively rare at this point. We often are not all in clinic at the same time. So we more often communicate via WebEx chat. So for those who aren't familiar, WebEx is kind of a Zoom software, but it's the one that our hospital uses, and it has a chat function. So we use WebEx chat. We use Epic messaging. Epic's the charting software we use, or Epic in Basket, where you can forward notes or documentation with notes attached to it, or just, some notes in general. We will email usually about non-patient needs if there's some sort of coordination or information, or if we're working on a project together, that's more likely email. And then for urgent needs, text message, phone calls. We meet relatively frequently. We have weekly psychosocial rounds where the psychosocial team, that mental health coordinator, psychologist, social worker, and in the past child life specialist, would all meet once a week together to coordinate around patient needs or any sort of projects we're working on together. More likely, like, urgent patient needs are the ones that are kind of more immediate. And then we also attend weekly center rounds with the whole Cystic Fibrosis Center, monthly clinic rounds with the whole pulmonary center or clinic. And then there's a daily huddle that takes place as well with our psychosocial team, in addition to our dietitian and our pharmacist. And that's to coordinate around the day and what needs there are for patients who are being seen that day. I think our team is unique in a few ways. One of the ways we're unique is that we have a number of psychosocial providers. So right now 3, previously 4, with some relatively recent transitions, me joining the team being one of those, and our child life specialist leaving the team being the other. So there's been a lot of adjustment that's come with that. and a lot of discussions and mindfulness about how we're managing that. We do have our weekly psychosocial rounds, which helps us to communicate really effectively around patient needs. We have a shared space with our pediatric and adult clinic and some overlap. And so, like I mentioned before, that has made transitions for patients relatively nice. I'm able to follow patients until they're 21 if I need to. So I can kind of be a transition point between the two clinics because we are co-located. And our mental health coordinator being a provider in the adult clinic is also an overlap, which is really nice for our patients as well. And then we are really intentional and have been really intentional about how we can use our roles for best patient outcomes, and being really mindful about being effective and efficient with how we're using our resources as a team. Some strengths, I think we are very effective at communication. We are very collaborative and collegial, and complementary strengths have really helped us to make sure that our team is as effective as possible. We are very much identified as a team within our center, and so providers and team members refer to us as the psychosocial team. And so if there is a psychosocial need and they're not quite sure exactly what that need is or how to address that need, they would come to us as a team together, so that we can then delineate roles and triage from there to determine who would be the most appropriate to address the concern, or maybe together we would be addressing that concern. And we have relatively clearly defined roles within our team, which has really helped us to do this. And I'll talk to you next a little bit about how we did that. So like I mentioned, I joined our team in 2020, in November 2020, about 2 years ago. And when I did, I think we realized that with 4 psychosocial providers on one team, there was potential for a lot of overlap and a lot of need for discussions about how to manage roles so that we're not all doing the same thing at the same time, and also so that we're not overutilizing resources unnecessarily. And so at the time, we sat down and we created this model of our team. So we very much conceptualize ourselves as this Venn diagram with individual and unique skills and qualifications, but also a lot of overlap in what we are skilled to do and capable of doing. And then we, from there, decide, like I mentioned, who is most appropriate to do that. We conceptualize that as in the context of some larger systems as well, of course. So we are within the system of our clinic, inclusive of all the dietitians and physicians, research, nursing, PT, all the things you're familiar with in your clinic. And then also embedded within this much larger community with which we interact on a daily basis as well, and who are also people who we serve in our roles. So case managers and community mental health providers, schools, pediatricians, our inpatient team, inpatient child life labs, all of these kind of external systems that we work within. And so we sat down and we said, okay, what are the things we're qualified to do? What are the roles we each have? And put them into our model. So our mental health coordinator, who I mentioned, works specifically with our pediatric team about 25% of her time. She works on our parent and family advisory committee, managing our family Facebook, collaborating with our local CF Foundation chapter, providing backup coverage for our pediatric social worker, a lot of education for families regarding mental health services in the community. She does a lot of our collaboration with community mental health systems to connect families with resources, address barriers to that, make sure she's following up on any mental health needs that our patients have via phone calls and brief counseling, and provide a bridge to services largely. She does a lot of continuity inpatient visits as well if any of our patients are admitted, and provides short-term counseling, which I may have mentioned that she does mostly telemed or over the phone, but in office as well. As the psychologist, a lot of my work is in a more formal, structured setting just because of the way our billing works in our clinic. So I do a lot of screening and assessment of behavioral and emotional symptoms that maybe are not addressed more broadly by other providers. I provide intervention for mood, anxiety, behavioral concerns, provide psychotherapy inpatient and outpatient, and that can address a wide variety of things, including procedural anxiety, coping plans, behavioral pain management strategies, pill swallowing, adherence, diagnosis. I do inpatient consults as an extension of my CL work in the main hospital. And I support our mental health coordinator, Layla, with referrals to community providers for some patients as well. coordinate with schools mostly regarding any sort of behavioral plans or behavioral recommendations. And then Kim, our social worker, does a lot more with the 504 plans and accommodations medically for patients. And then do training and education about psychological factors that might affect the patient's medical condition. And our social worker does in and outpatient social work support, identifies resources for families, including health insurance support, financial resources, FMLA, Social Security, transportation and lodging. We have a large Amish population, so there's a lot of Amish assistance programs that she works with, coordinates with community agencies like CPS and Child Services, tracks our appointments not kept for patients and makes sure that those patients are able to get in for appointments. She does our annual psychosocial assessment and our mental health screening. Is a good community liaison and coordinates with a lot of our community agencies who want to provide our clinic support. Works with schools on education around CF, 504 plans, and those types of things. Also, in addition to our mental health coordinator, helps with managing our family Facebook and our parent and family advisory committee, and also works on our clinic newsletter that goes out to families. So lots and lots of jobs. We do have a ton of shared roles too, and that is something we are very aware of. And a lot of things we all work on together or would all be qualified to work on if we were asked to. And so we just decide amongst ourselves at that point. So parent education, advocacy work, brief interventions in clinic, work towards helping patients be more adherent, and that can look different depending on what the need is. Supporting medical decision-making, educating providers, inpatient visits, quality improvement, transition, research, staff education. These are all things we all kind of overlap on. In a lot of ways, how we do those jobs maybe looks a little bit different, but the larger task of doing it, we all are able to do and often do. We've had a number of changes that have either been due to COVID or have just timing-wise coincided with COVID. So I joined the team in 2020. I interviewed in February 2020, just before COVID started. So that has been a bit of an adjustment. I've only known our clinic in the context of COVID. And so some people I have not even seen their lower faces. We have done a lot because of COVID with increasing formal communication with our team, and there's been a lot less of the informal communication. We've had to be a lot more mindful and intentional about how we communicate because we don't have that on-the-fly interaction quite as much as we may be used to. That's less and less recently, but it has been still the case, I would say, from what I know at least. We've done a ton more telehealth. For me, I'm still doing mostly telehealth visits. Part of that is because we changed locations for our clinic and we're in a much smaller space and there's not a whole lot of room for me. But also it's just a nice service that we can provide and access some of those patients, like I mentioned, who are further away in the northern or southern tier. Speaking of when I interviewed in February 2020, one of the providers in our clinic really, really wanted me to do telehealth at the time. And he was like, you got to do telehealth. It would be so great. And I was like, I don't know. Like this, we don't know about the research. It's like mixed research and the billing and the location and the ethics and the this and the that. Well, a month later, my whole fellowship was on telehealth, and I was like, okay, guess we're doing it. So he got what he needed, and it really has been really nice for our clinic to be able to have that and for me to be able to provide that service to patients who would not have otherwise been able to access it. And I think my show rate is much better for my telehealth visits than my clinic visits as well. We have had a lot more demand, as I'm sure you all have, for psychosocial services with COVID. And like I mentioned, we changed our clinic space. They needed to use what was formerly, at least my understanding, what was formerly our clinic was right behind the emergency department. And so when COVID happened, they needed extended room for the emergency department, so we got moved somewhere else. Now they're using it, unfortunately, for mental health overflow, which is, I would say, also a pandemic in its own right at this point. So that has continued to be a bit of a change for us. Some challenges, of course, we've had some significant professional transitions in our team. So I joined, and so I've had to figure out billing, which is a little bit complicated. In our clinic, I have to bill mostly psychotherapy codes, and so that has affected a little bit of what services I'm able to provide and which services other providers will provide instead. And like I mentioned, I do a lot more formal visits than I do on-the-fly consults in clinic or other types of services. I also mentioned in our new space, it's much smaller. There's not a lot of space for hour-long psychotherapy visits in our clinic, and so I've had to figure out other things like using telehealth. We did have our child life specialist leave for a different position. That was a big loss for us. We are very hopeful that at some point we will get another child life specialist. But she was doing a full-time job of being a child life specialist in our clinic, and those were things that our providers in our clinic started to expect and like and appreciate about what our psychosocial team was able to do. And those are things that as a psychosocial team of 3 now, we don't really always have the capacity to provide those services. And so there's been a bit of an adjustment of picking up some of those pieces that we can and have the ability to pick up, but also having to leave some of those things uncovered at the moment just because we don't have the capacity. I don't have the opportunity like our child life specialist did to jump in on any sort of procedural issues in clinic. If there's a phobia or something, I'm able to jump in and like provide psychotherapy to address the phobia. But if it's a more in clinic, on the fly kind of thing, that's just not something I can do. So we've had to kind of adjust, and I'm doing a lot more of things like pill swallowing and procedural distress than I was before as well. And I know our social worker and mental health coordinator are picking up a lot of additional roles as well. A lot of coordinating of community things that our child life specialist was formerly doing as well. We have, because of me being added and our child life specialist leaving, had to make sure that our team is up to date on what services we are able to provide and establishing an understanding amongst them of our workflow and what we're doing and how we're doing it. And that has changed a little bit with providers in and out. We do a lot of staff education to make sure that is working. We are not co-located with our clinic. We're all in kind of different spaces. So I mentioned our offices and where I work and where social work and mental health coordinator work are located in our main hospital location where our clinic used to be. Our children's inpatient hospital is attached, but in another separate location, probably about 7-minute walk away. And then our clinic is in another building, and that's another 10, 15-minute walk away. If you're fast and speedy, it might be shorter. Speed walking on a mission. But so we've had to we're all spread out now, and so that's made it a little bit more complicated for us to coordinate. We're hopeful that we'll be moving into a new space. I'm told that that's been said many times before and hasn't happened. So as a newbie, I am naive and hopeful. So the other thing that we've had to adjust to is privacy during telemed visits. I think that this has been something that we've had to be a little creative about. So the way telemed visits were working is that everyone was together on a call, together listening to everything. And so that didn't leave a lot of opportunity for families to have some private moments to discuss something that might be a little more sensitive. And so we've had to do a little bit of making sure that psychosocial assessments or discussions happen at the end of visits so that we can kick everyone else off, or using the mute button really intentionally and that kind of thing. And then open note, I'm sure for all of us, has been a bit of an adjustment. Less so than I expected as a psychologist, to be honest, but it has been still something that we've had to be mindful and intentional about. There was a lot of discussion early on. There was, at least for me, I think maybe for others, some cases where things got a little dicey while we were figuring it out. But that has been a bit of a challenge to figure out how documentation does or does not need to change now that families have access to it 100% of the time. So just for some context, I'll give an example of what our role might look like for a patient. So for a high school age male with a complex CF presentation, anxiety, school avoidance, and parent mental health concerns, we would split our roles like this. So the social worker would provide resource support and mental health screenings in line with the protocol and the recommendations. The annual psychosocial assessment would coordinate regarding the 504 plan with the school and any needs that the school might have for 504, and coordinate with them about education with regard to cystic fibrosis, and also provide family support on medical decision-making or decision-making around how to manage those pieces of the patient's care. I would provide education with the team about behavioral recommendations for managing and emotional recommendations for managing anxiety, school avoidance, those kinds of things from a psychological perspective, and then would provide psychotherapy via telemed or combined with clinic or in person if they would prefer as a separate visit. And then the mental health coordinator, prior to my involvement, might provide intervention via supportive phone call or bridge counseling services. If the family is not interested in services with me or I didn't get to them yet, they might be referred to community agency, and our mental health coordinator would support with that and would support the family with accessing mental health resources for themselves as well out in the community. And so this is just a general idea of kind of how we would split and delineate roles for a case that would involve all of us mostly at this point. Now, had our child life specialist been involved in this case too, she would meet with the family regularly in their clinic visits, assess just general functioning emotionally and socially and behaviorally, would provide supportive interventions around adherence and around like typical development, and would provide any sort of procedural support that was necessary as well. This is my contact information if anyone has any questions or concerns, and I'm looking forward to any questions later if you might have them. Thank you very much.
Thank you so much, Dr. Nicholas. We forgot to mention questions at the beginning, so, there you go. So if y'all could, please do enter questions into the app. We will be doing questions all together at the end. We really want you to hear a bit about each of these different amazing programs. So go ahead and enter those, and we can also use the mic at the end for questions. So I want to introduce our next team of presenters. So we have Meg Dvorak and Dr. Lisa Scher to talk about their amazing program at Stanford.
It's this one?
Just for the first slide.
And then it's that one? Okay. Good morning, everyone. Thanks for getting up early and coming to our session. I'm Meg Dvorak. I am the adult social worker at Stanford Healthcare, and I'm going to be presenting about our mental health care team, along with my co-presenter, Dr. Lisa Scher. And this is our disclosures slide. So this is a picture of our mental health care team, which includes myself, Dr. Scher in the middle, my co-presenter, and my social work partner, Kate Yablonsky, on the right. And today I'm going to be talking about how we came to be and how we currently operate as a mental health care team. I'm also going to be briefly presenting a case that highlights our strengths. And then Dr. Scher is going to come up and she's going to talk about some of our mental health trends on our care center team over time, and then just the general value and impact that good mental health care brings to people with CF. But first, I want to just review the composition of our medical team as a whole. So we are the largest adult program in California. We are connected with our pediatric program as a single CF center. And the program split off from one another in 2009. And since that time, both programs have really grown significantly. In our adult program, we care for approximately 250 adults. That number seems big. I know it's sort of plus or minus, and it includes post-lung transplant patients. And we care for our patients both inpatient and outpatient. We have clinics nearly every day of the week with 2 really large clinics per week. And we offer mostly inpatient or in-person visits for clinic, but we do offer telehealth for select patients based on clinical criteria. And that would include pregnancy, sort of towards the end, people who are post-lung transplant, or some of our patients that have to drive a great distance to the CF center. And you can see our medical team listed on the right, our mental health team at the top, and then we have 2 pulmonologists, soon to be 3, 2 APPs, 2 RTs, we have a dietitian, and then 2 amazing RN coordinators that do so much legwork for our program. We have a fellowship program at Stanford, so pulmonary fellows are always circulating through our clinic. And then we have really close relationships with specialties such as infectious disease, endocrine, and urology. And then we have a well-established lung transplant program at Stanford. So our team has come a really long way in the past 12 years. And this slide illustrates the timeline of sort of how we came to be to the present time. Back in 2009, our adult CF program was just starting off as an independent program. We had just split off from pediatrics. And at that time, there was only a 0.5 FTE devoted to a single social worker. And I joined the team in 2010. And then, shortly after, just a couple of years, I had increased my FTE from 0.5 to 0.6. And then throughout that time, Dr. Scher was starting to build her practice of CF and lung transplant patients in her medical psychiatry clinic at Stanford. And then in 2016, Dr. Scher and I applied for the mental health grant, and we got it, which was great. And she joined our team shortly thereafter, followed by Kate Yablonsky in 2018. Then in 2019, we secured funding to keep Dr. Scher on our team after the mental health grant ran out. And that was huge for our program. And it really wouldn't have been possible without the unwavering support of our medical director, Paul Mohabir, who really believes firmly in mental health care in our program. So from 2019 up until the present time, the three of us have worked really, really well together. We have a shared desire to elevate mental health practice in our CF clinic, and we want to keep innovating and developing projects together. One such project was Kate resurrecting our CF PFAC, which had really disbanded during COVID. So this slide illustrates the clinical responsibilities of our mental health care team and the percentage of time that we all devote to CF. You can see it's kind of slightly different. We all have different duties and roles. And Kate and I tend to focus mostly on psychosocial things like annual assessments. We follow our patients when they get admitted. We provide letters to patients. We do a lot of end-of-life and advanced care planning, advanced directives, and counseling and crisis support, all the things you can see there. And Dr. Scher conducts psychiatric evaluations in the clinic, medication management. She handles all of the data management for our mental health screenings, which gets reported to the foundation and the Port CF. She does consultation and psychotherapy and much more, as you can see. So our roles tend to overlap most when it comes to mental health screenings, assessments, and interventions. And I actually think that's a really good thing. Our patients have come to know all three of us separately. They all have separate relationships with us. And so they've come to really rely on and appreciate the mental health care that they get almost every time they come to CF Clinic. And it's also great because we all know the patients really well. We can jump in and cover for each other when someone is out or when there's a vacation. We are in almost constant communication throughout the work week and reluctantly, sometimes even on the weekends. For secure, really confidential patient information, we tend to rely on secure emails, Volt, phone calls, and Epic messaging. We love Epic messaging because it allows us to send chart notes between each other, either as an FYI or to ask someone for follow-up on a patient. Like, for example, I'll see somebody for therapy and then the person seems to be in crisis or they're asking about medication, so I can message my note to Dr. Scher, say, hey, please follow up. This patient's asking about their meds. For our medical team, most of our meetings since COVID have been on Zoom, unfortunately. We have a really, really active text thread on our team, which has actually been going quite a bit during this conference. And then I think most importantly, we have a lot of informal communication that happens right in our clinic workroom in real time. We're together for close to 4 hours, 2 days a week, and a lot of that communication ends up being quite productive. So in terms of strengths, I think what stands out most is the fact that Dr. Scher is an embedded psychiatrist on our care team. As so many of you know, access to psychiatry is just vital for the mental health care of people with CF. And even the best insurance plans make it difficult and expensive to get. Dr. Scher is ever present on our team. She's in all of our clinics, and patients even without mental health conditions have gotten to know her really well. Thus, it just destigmatizes psychiatry and it removes barriers. And second strength is that patient care is really our number one priority. We want our patients to have immediate access to mental health care, whether it's therapy, medications, or both, or something else entirely. And that would be regardless of their insurance status. And so to help meet some of that increasing demand, I developed a small CBT, cognitive behavioral therapy practice in our CF clinic, where I'm seeing patients mostly with access and insurance barriers. But a lot of patients just really don't trust providers that don't understand CF, or they've just tried to find a therapist and there just aren't any. And I'm sure some of you are experiencing that too. So you can check out my work at poster 285 in your app or in the poster hall. Our mental health team also guides and supports our medical team during difficult moments. So in those early scary days of the COVID lockdowns, our team was just freaked out. And Dr. Scher offered wellness meetings on Zoom for the medical team, and that wasn't even to do with anything patient care. It was mostly for the team of how are you guys coping? How are you guys managing as providers? What are we gonna do? We also just provide therapeutic support to our team members who are burned out or having a difficult day in clinic. My colleague, Kate Yablonsky, sends cards out to bereaved family members every year on the patient's birthday. If patients die, we offer mortality debriefings. And another thing Kate started, which I think is so cool, is the Breathe Easy board. And that's where we put pictures of patients who have passed over the years so that they're never forgotten. And of course, this board is in a non-patient area. And next to the baby board, next to the Breathe Easy board is our baby board. And that's a board where we put pictures of all the babies that are born to our patients with CF. And it's gotten very, very busy since Trikafta has come out, as I'm sure some of you have seen in your clinics too. And so visually, these boards right next to each other, they just provide this beautiful visual circle of life that helps our team really cope with some of the heaviness of the work. Our mental health team is also really active in the national CF community. We do all three of us run support groups. We offer talks, speaking events, we run workshops. We're also involved in the academic community, publishing, getting involved in research. All three of us have written book chapters, and we're all required to do a QI project every year. So you could check out one of our most recent QI projects, poster 321, on advanced care planning. And then lastly, we write wellness newsletters every couple of months. And these are on a variety of topics that really relate to all of our patients. And those wellness newsletters are given out to all of our patients in CF clinic for that time period. And you might have seen these wellness newsletters on the listserv. They go out whenever we have them. And those are for you guys to use and adapt to your own care centers as you see fit. So as with any busy healthcare system, things are always changing. I feel like every year there's a new policy or there's something new going on, and we're challenged in many ways. And it was really, really difficult to get Dr. Scher's position funded. Not only was it a budget issue, but it was a political one as well, just because we're dealing with not just Stanford Healthcare, but Stanford University. And so thank goodness for our medical director who really goes to bat for her. But we're anticipating that this funding issue may come up at some point in the future. We may have to cross that bridge again. But it's been so invaluable having her on our team. And then, of course, I know grown billing, always an issue. So many of our patients have government insurance, so Medi-Cal, Medicaid, and just really cannot link with good mental health providers who understand and know CF in the community. And then with COVID, we saw so much increased demand for mental health care, and we're just a little team of 3, and sometimes we're stretched a bit thin to provide all of the need that's out there. And then, of course, the overlapping roles. I think the last speaker did such a great job, like illustrating that, and I'm just going to briefly state that our roles do overlap, and when that happens and we're in clinic, we both want to see the same patient, like Dr. Scher, Kate, and I, we tend to talk about it ahead of time, and we'll make a plan. And Dr. Scher would cover a psychiatric need or a medication check-in, and then Kate and I would cover more of a psychosocial need. And then sometimes we see patients together, and that's sort of case by case, and a lot of patients really enjoy those combined visits. So next I'm going to just talk about a case we have in our center that really highlights our strengths as a team. Patient is MS, a 22-year-old transgender patient, female to male, with CF, moderate lung disease, and was started on Trikafta in 2019. MS has a history of childhood trauma, medical trauma, anxiety, panic attacks, depression, and just a very, very limited support system. MS has Medicaid insurance and thus really could not link with any providers in his community. Thus, he was totally dependent on our mental health team for his mental health care. And you can see that the meds that he's on, prescribed by Dr. Scher, some of these meds have been tweaked and changed over time. MS started in the CBT multi-center pilot study in 2020 with me as his interventionist. And after the study was over, his mental health had improved a good bit. But unfortunately, as we know, mental health is really kind of a chronic thing. And the following year, his anxiety came back and unfortunately was much, much worse. So Dr. Scher and I had to collaborate really creatively and closely on providing crisis support for him throughout that time, and almost week-to-week medication check-ins and adjustments. And also at that time, I had picked him up in my new therapy practice that I had started. So I provided 22 sessions of CBT to MS, and much to our surprise, he came out as transgender during that time. And then he discovered that so much, after he had come out, so much of his anxiety was related to gender dysphoria. And so almost immediately after coming out, his mental health improved significantly. He began to thrive in his life, and he's now going through a full medical transition. And so he eventually got connected to an online trans therapist. He's getting more integrated into the trans community. And our mental health team was able to assist our medical team in providing good gender affirming care, which was really a first for us. So he was a good experiment for that, because I think we have other patients that are coming through that. And we continue to advocate for him on this journey of transition. So now I'm going to turn it over to Dr. Scher, and she's going to be presenting some of our center's mental health trends and a lot more.
Okay. Well, thank you, Meg. That was a great overview. So it's so nice to be working together with you and Kate, and really for me working with our CF clinic And community has been an amazing professional and personal journey. And, I just kind of remember like the line from your slide that psychiatry has been stigmatized, which is true. But I remember when I introduced myself the first time within the clinic, it was on my first visit, and I came into the room and I said, "Hi, I'm Dr. Sher, I'm a psychiatrist on the team." And the patient was like, "Oh my gosh, what did I do?" So for some time I was like, well, I'm part of the team, I'm a mental health coordinator, I happen to be a psychiatrist, sort of like. And at this point I'm back to saying I'm proud that I'm a psychiatrist and nobody's scared of that anymore. So that's good. So there's been an evolution of that. So for some time I was apologetic for that fact. So just as just kind of an overview of some trends, right? So this table represents our screenings, right? And the numbers represent percentages of patients who have been screened and screened into a particular group, right? So if you kind of see that first, it's like third column, right, 2016. So out of the patients who were screened 2016 by PHQ-9, 68% of patients screened into no to minimal group, right? So meaning they screened 0 to 4 on PHQ-9. 20% into minimal symptom group, 5 to 9, right, on the PHQ-9. And then 12% into moderate plus group. So moderate, moderately severe to severe, because the percentage is kind of not that great, thank goodness, so I've combined them here. So patients who screened with any symptoms on PHQ-9, so, it were 32% of the patients who were screened. And we see that in 2017, that was actually pretty similar, right? So roughly 2/3 have screened with no symptoms, and roughly 1/3 have screened with mild plus symptoms. We compare that to 2021, so this is the year for which, of course, we have the latest full data. And the numbers are actually pretty similar, right? So again, 69% no to minimal symptoms, and then, minimal symptoms, 17, so maybe decreased a little bit, likely not statistically significant, and more patients maybe kind of switched to moderate to, kind of moderate plus group, but again, I don't really think that's statistically significant. And then when you look at GAT7, similar trends, right? So overall, we see those trends of, non-minimal, moderate plus, or any symptoms, maybe bounce around a little bit within the groups, but overall, actually pretty stable. So this is, again, the same data represents it more in a graph form, right? So you kind of see the blue line of no to minimal symptoms on PHQ-9 and GAT7, and then the yellow line is any symptoms. Minimal symptoms is orange, and this, whitish, grayish is moderate plus symptoms. So there might have been, again, right, kind of a little bit of change, decrease in moderate symptoms, and again, COVID and everything else has happened, and maybe, again, more patients are presenting with more moderate. So in 2021, out of those patients who were screened and have all the data, right, 176 patients, so this is just some of the statistics that I can show you in terms of my role on the team. So in 2021, out of the, again, patients who've screened and we have all the data, I have seen 62% of those patients, right, so 110 per year. And some of those patients I've seen once for one-time evaluation, consultation, some of the, and actually a lot of patients there's some patients that I see almost every time when they're in clinic. And I also, right, so I'm, as Kate mentioned, 0.3 of my FTE is devoted to CF clinic. So I'm there in person, our 2 half-day in-person days. And the rest of my time, right, I do a lot of inpatient psychiatry, which is actually a lot of the ICU psychiatry, or consultations to CF team. That sort of rarely happens now, but if need to, I will of course see patients inpatient. And also my psychiatry practice in medical psychiatry, where again, most of my patients actually are still CF patients, pre and post lung transplant patients, and some other medical ill patients. But for me to be able to see patients on the psychiatry side, they have to have, particular insurance, right? And that's a barrier. And in CF clinic, I can see anybody, right? So those patients who do need additional support and have insurance, right, then I can see them on the psychiatry side. So there's some overlap there as well. There are some patients that I follow very regularly in the psychiatry side and also do psychotherapy in addition to medication management. So this is interesting, right? In 2021, again, out of, let's say 176 is like full number, right? I have prescribed patients to 31% of our clinic, so I prescribe psychotropic medications, right, 1 or more. And then half of those patients, right, so 17% of the kind of, let's say, clinic patients, they would not be able to see me in psychiatry clinic. I can only see and manage them within the CF clinic. So these patients would not have gotten care if I were not able to see them. And then, there's some patients who, thank goodness, are managed by community psychiatrists as well. There were some patients who were managed by community psychiatrists prior to my role, but they kind of felt it easier than to switch over and sort of have, their needs met. So it's not like I came and I started prescribing to everybody. But, maybe in 5 years, maybe it'll be 100%, who knows. So, but there's definitely patients who have switched over just because it's so much easier, right, for continuity of care. And so, 38% of our patients do receive one or more psychotropic medication. We can say, is it great, is it not great, but those are the numbers. So if you're wondering what kind of medications they are, right? So again, these are 67 patients who are on psychotropic medications, and half of them receive an SSRI, right? So either by itself or with something else, right? So most commonly it would be escitalopram or sertraline, some patients on fluoxetine, some patients are on fancy things such as Trintellix, but 55% are receiving SSRI. And of course, SSRIs are used for both anxiety and or depression, right? And then other antidepressants, 66% of patients are on other antidepressants, right? Such as mirtazapine, bupropion, duloxetine, which is SNRI, and again, by itself or in combination with other medications. Patients, so 3/4 of patients are on any and only antidepressants, meaning they receive any type of antidepressant either for anxiety or depression. And that's, maybe it's just one or several, but they only receive the antidepressant therapy. Again, that means that they have likely an anxiety and or depression disorder. 22% of patients are on some sort of mood stabilizers, right? Again, by itself or in combination. And these are medications such as quetiapine, olanzapine, really few patients. Usually these patients might have some mood disorders, right? Maybe kind of mood disorder not specified, bipolar disorder, like treatment-resistant anxiety, lamotrigine, again, for mood disorder. Pregabalin, so that's often used for bad anxiety or for neuropathic pain. I do see myself also in the clinic managing other concerns, not just mental health concerns. I manage sleep, I manage pain, I manage nausea. So I manage all other, somatic symptoms as well. So, few patients receive benzodiazepines kind of as needed, not that many. And in 2021, 7% of patients, or 5 were prescribed stimulants for ADHD. I have to tell you that, when Kate looked at it, she's like, this is not, there are more patients on stimulants. Yeah, this year, there are definitely more patients on stimulants. This number at least is doubled. Because ADHD actually is also much more common in patients with CF, right? We know that at least roughly 17 to 18% probably have ADHD as compared to 7 to 8 in general population. So this is something that I'm actually much more aware of and screen for and prescribe medications. ADHD can definitely affect adherence, quality of life, and so many other aspects. So I do find myself using this intervention with success. And so half of the patients receive one psychotropic medication, and then half of them, maybe it might be like trazodone or hydroxyzine as needed, right? Just something for anxiety or sleep, and then half of the patients receive 2 or more, okay? All right. So in terms of, psychotherapy, I have, in the last year, provided approximately 13.6% of the patients that were screened with psychotherapy, and this number has decreased because MEG has been doing so much more psychotherapy, and we have also been a part of this multi-site CFCBT. So in 2021, we were lucky to be able to provide a lot of interventions within that context. So again, just comparison in terms of 2017, 2021, more patients have been seen by psychiatrists in clinic, more medications have been prescribed. Therapy might have been decreased by me, but overall as a center, we have been able to provide much more psychotherapy within the study, and also with MEG doing so much more psychotherapy right now available to our patients. So just some of the trends, right? So definitely, the team, our psychosocial team is very integrated. We collaborate very closely, able to see, to see more patients and evaluate them. And sometimes just even seeing patients who don't have acute mental health needs is very helpful, because sometimes you would come in and they say that everything is fine. But when a need arises, they know your face, so they're able to reach out, and we've had those patients. As we said, mental health has been destigmatized and normalized, And people are really asking for help and interventions. Like, it doesn't seem there's shame about this. They can reach out to any team member and say, hey, can I see Dr. Scher, right? And I have a question. So I think there's just a much easier conversation about that in general. More medications have been prescribed. Overall, more therapy has been delivered. And mental health scores have been stable and not worsening. But we can also if we look at those numbers, right, we can also question that and say, well, with all those amazing interventions and time and therapy and meds, how come those PHQ-9, and GAD scores are stable and maybe not improving, right? So I have a few theories about that. First of all, I think we have really low mental health scores at baseline, right? Just 30% of our patients, according to PHQ-9 and GAD-7, do report mild or any symptoms. And it's comparison, I think, from CF Foundation data that it's approximately 45, 46%, nationally report elevated PHQ-9 and GAD-7 scores. We also know that these are not great scores, to be honest. They didn't truly pick up on all the emotional distress, right? Sometimes patients just check off zeros. And then, of course, with Trikafta, there are a lot of positive changes, right? But also, there's existential changes, right? As I think we've heard in some other lectures, right? Living more, it can be stressful, right? There's just so much that comes with that, right? And then those patients who don't qualify, right, have side effects, don't respond. Are there mental health side effects, right, to medications like Trikafta? With the weight gain, right? Are there other mental health concerns? And of course, at the same time, the pandemic has happened, right? So the world events, everyday life stress, right? I also think, right, the goals in terms of treating mental health, it's, we can't just cure away the emotional distress and depression, anxiety symptoms that we pick up, right? People will continue to experience stress. And there are lots of challenges, right, in the world. So I think this is something that we will continue to work on, and this is going to be also a chronic disease process. All right, so that's all that I have for you. So thank you.
Thank you so much to our Stanford team for sharing that. I want to invite Stacy Smith up, and we're going to hear a bit about a very unique program. Slide up.
Hi, everybody. Can everybody hear me okay? All right, thanks for coming. So I'm Stacy Smith. I am the social worker at the Complex Care. We are located in Rochester, New York. And I'm going to talk about the integrated and embedded health, behavioral health, and support services. I have no disclosures to present. So an overview of the clinic. We are a primary care clinic with embedded services that include services such as physical therapy, respiratory therapy, registered dietitian, pharmacists, different behavioral health, applied behavioral analysis, care management, dental, and we also have a lab right on site. Our current registry is around 1,000 patients, give or take a few. I started this slide presentation in July, so we might have a few more, might have a few less. Our CF patients are about 101, give or take a few as well. Like I said, our clinic is located right in the city of Rochester, New York. We are on public transit routes, and we are about 3 or 4 blocks from the RTS, which is Rochester Transit System bus station. Our clinic population, the places that the individuals that we service, the CF, apparently this one is a little bit more accurate, is about 106. Sickle cell is another diagnosis that we focus on at the clinic, about 101 patients. Patients with intellectual disabilities is about 387. Patients with autism spectrum disorder is 310, and we also service individuals that don't actually fall into any of those categories, and that's about 267 patients. So these two slides just show the breakdown of the different diagnoses, mental health diagnoses inside the clinic. For the patients that are without CF, depression obviously is a pretty high factor, anxiety a lot higher. Those percentages look about, sorry about that, I have the numbers, not the percentages. About 201 patients that do not have CF in the clinic score with depression, about 333 score with anxiety, 48 with adjustment disorder, 134 with PTSD, and then those that don't score any is about 423. In the CF population, those with depression is about 26 patients, anxiety is about 27 patients, adjustment disorder is 3, none score with PTSD, and none of the above is about 61 patients. The structure of our clinic. So we have 10 clinics a week, 1 in the morning, 1 in the afternoon. We have pre-clinic planning sessions every day right before both of those clinics. The first one at 8 in the morning, the second one at 1 p.m. to allow for multidisciplinary care coordination. So what usually happens is we read off the patients that are coming into clinic that particular day, and if there's anything in particular that we want to touch base with, whether the medical provider wants to, ask maybe a care manager, which we also have embedded in the office. Hey, last time I spoke to this person, they said they were having issues with housing. Do you think you could pop in and maybe talk to them about some resources that are available? So we have the availability to have those conversations right before the patient comes into clinic that day. We do have specialty CF and sickle cell clinics twice a week. This allows for all of the disciplines to be right there in the office and available for patients. Say if they're in clinic, they are just there for a regular visit, but then they say, hey, I really think I need some help with behavioral health. The provider can be like, hey, I'll contact the social worker, have them come down, talk to you about some possible resources that we can either offer you here in clinic or in the community. So that is very beneficial because they have access to almost all providers right there in those clinics. Sorry, I get nervous and I don't breathe. All right. So some of the cool things about those clinics, even though that all the disciplines are there and they're specifically set for like either a CF clinic or a sickle cell clinic, it's pretty cool because other patients can still come in. We won't say, oh, you need to have a doctor's visit today, but we have a clinic, we have CF clinic today, so you can't come. We won't say that. We still allow for those patients to come in during those times, and we don't force that the CF or the sickle cells only come in during that clinic. Like they can come in at any time during our 10 clinics a week. The mission in the clinic is to enhance health outcomes, overall well-being, and the quality of life for our patient population. This is done through screening for identification of individual needs and providing individualized, short-term, evidence-based interventions to meet those needs. We also work on developing programs to support the caregivers and the family members of those individuals that are caring for our patients. So now I'm going to focus a little bit more about the behavioral health that is in the clinic. It's considered integrated behavioral health. It was created at a hospital-wide initiative to embed behavioral health in primary care clinics. When I started, currently had 2 part-time psychologists. Right now we are looking for one to cover. We have a consulting psychiatrist, and I am the social worker, and we do offer time for trainees and interns as well. The services that we offer in the embedded behavioral health are assessment, short-term treatment, consultation, annual mental health assessment, population-based screenings, and we also offer support to caregivers, and we do have applied behavioral analysis support services right in clinic as well. So each one of the clinics has clinicians have scheduled for set appointments, the ones that provide the therapy. And this is done with like warm handoffs, consultations, safety assessments. Notes are included in patient's regular medical chart, so that allows for everybody to be able to see those, that information, and there's no need to worry about whether or not we're in different systems to make sure communication is held. The behavioral health treatment is offered at a short-term evidence-based intervention. The primary focus is acceptance, commitment, therapy. It focuses on increasing psychological flexibility across 3 pillars: openness, aware, and engagement. Sessions are generally very brief sessions, traditionally psychotherapy for about 6 months to a year. The psychiatrist consultation, we have a consulting psychiatrist available for 1 half day a week to assist with diagnostic questioning and make recommendation regarding medication management. The referring provider identifies if that one-time consultation or 2-time consult and treat. The one-time consult, psychiatrist sends reports with recommended changes to the PCP to initiate, and a 2-time consult is treat. And treat is psychiatric makes medication changes and sees back in 3 weeks or 6 weeks. I complete the annual mental health assessments for all the patients that come into the clinic. A lot of this is done through the tablets. We are able to hand the patients the tablets when they're in their waiting room so they can do the screenings, and then I can just pop in for like 5 to 10 minutes and discuss what those results were. Sometimes I do have to go in and complete those for our patients that have intellectual disabilities. They really can't be screened with the PHQ. Some of them can't complete it on their own, and or the questions really don't ask them the way that they would understand. So in those situations, we use what is called the Glasgow, and that right now we do not have on the tablet. We are working to get it on the tablet, but right now it is not on there. So I have to actually do that in-person interview style. But so I started with doing the mental health assessment with just the CF patients and the IDD patients, just to get us up to par to where we needed to go. If any concerns are identified, recommendations include either behavioral health that is right embedded in clinic, or a collaborative care program, which I will explain to you in a bit, or we also offer care management in our clinic, which also I will talk about a little bit more. So this is just a made-up case example. So Johnny's a CF patient. He scored a PHQ of 6, a GAD of 7, working with the clinic psychologist in the past but isn't currently, suggested re-engagement because of the scores, routed note to the PCP and the psychologist, messaged the front desk to schedule an appointment, and all information lives in the Peachy chart and is provided to review. So the care management services, which I wanted to explain to you. So we offer care management service underneath both the Office of People with Developmental Disabilities, which is the agency in New York State that offers services to people that have developmental and intellectual disabilities. We have 4 care managers embedded from the 2 agencies that provide care management services for those individuals, Person-Centered Services and Prime Care Coordination. They work at those agencies, but they live in our office. These individuals are there to provide support, facilitate, and help with healthcare needs and resources into community resources that are available to those individuals. We also have the health home care management, which is offered mostly to our Medicaid patients. And they do a lot of the similar stuff that the OPWDD care managers do. However, they don't work underneath the OPWDD banner. But they do help to assist with coordinating care, making sure they communicate with their doctors, making sure that they have access to the different resources that they may need, whether it's housing, transportation, insurance concerns, or food insecurities. Another program that we also offer in the clinic is called collaborative care management, sometimes called depression care management, depending on who you're talking to. This is a program that I man myself. I like to call it therapy light. It's not real psychosocial therapy, but we work on a lot of different things like problem solving, coping skills, some motivational interviewing, just to pretty much help those patients that have higher PHQ or GAD scores to try and lower them when they're not actually ready for true therapy. Right now, we are currently looking for a new home for our bereavement tree. This tree obviously is focusing on patients that we have lost in the past. And we send out a card to all the families about whenever this happens. Most of the clinic signs it, and it goes out to the family. And we try to memorize all those people that we have lost from the clinic. Changes that we have faced due to COVID. We do a lot of telehealth services. The behavioral health side does a whole lot more. The medical side did transition to more in-person, but a lot of our behavioral health is still focused on telehealth. We are able to conduct screenings, whether telehealth, on phone, or just popping into a doctor's visit. I do that a lot of times. I find myself sitting quietly quite often in a doctor's visit waiting for my turn to speak. Challenges that we face. The clinic can't really rely on fee-for-service model, so we do look elsewhere for billing, like the depression care management program, which allows me to provide some mental health services to patients that either wouldn't have access to it or are not ready to do full-on therapy. And that service, the way it is billed is as if you're just visiting your PCP doctor, but you're actually getting mental health services. So that was a added addition that we really enjoyed. This is picture is about a year old, so there are some individuals that are no longer in the clinic, but my favorite line when it comes to a team is teamwork makes the dream work. And I would say that our team works amazingly well together. I think we do great with providing care to our patients, and I have heard from several patients that they really do enjoy coming to our clinic and working with our providers. And obviously I hear questions are being held to the end. So.
Thank you so much. And our last presenter for today is Elisa Gray. So I want to welcome you up here to share about your program. There we go.
Hi, everyone. I'm Elisa Gray. I'm from
Children's Hospital, Colorado, and I'm excited to share about our programming. Let me get started. I have no disclosures. I wanted to start by outlining the growth of the team over time. I did a little bit of research as well and was trying to figure out when we got social work and when we got accredited as a center, and it also went back to the 70s. But I started this in the 90s when officially our clinic was developed, and we had minimal social work support and actually no psych support, which I think is pretty common. In 2002, our patient population was up to 365, which is about what it is currently at. We had 0.5 social work and still no psych. So as we go along, we have a little bit of gain in social work over time. And then we finally get some psych support in 2014. Around 2018, we got the mental health coordinator grant at our center, and so that increased some of our psych support. So that you can see in 2019, we have 2 FTE of social work and 2 FTE of psych, which is where we currently stand. This is a general overview of what our clinic looks like. We still serve around that 350 pediatric patients. We have the 2 social workers, 2 psychologists. We also have psych fellows and interns and externs, which gives us a lot of extra support, which is great. We have clinic 4 days a week. Thursdays are our admin days. So I kind of outlined on Thursday, we do a lot of communicating with other team members. We have our weekly psychosocial rounds. We have our CF team meeting. We do rounds for clinic on Friday and Monday, and then we also set aside time to talk with other disciplines such as nutrition. I have that one on there. And later on I will talk about, we started a transition to adult care clinic, and so that is quarterly, and that also falls on that Thursday. A couple other cool things about our center is we have a Spanish-speaking provider and also now a Spanish-speaking social worker, and they have slotted time for clinic 1 time a week, which is amazing. We have satellite clinics at both a north and a south campus that our team travels to, and that occurs once a month at each of those locations. And then, as I mentioned before, we have a transition to adult care clinic that happens quarterly. And our psychosocial team follows our patients both inpatient and outpatient. So I wanted to outline the roles of our psychosocial team. As discussed, like in previous presentations, there is an overlap. And I started on this team 2 years ago, and our team worked really hard to find a really good balance. These things aren't set in stone. They're just a general idea. We overlap or cover for each other as needed, but psychology is the lead for the patient mental health typically. They administer the patient mental health and behavioral health screeners, so those are the PHQ-9, GAD-7, PSC-17. They provide outpatient mental health services to our CF patients, which is a huge benefit. And they provide behavioral support such as feeding adherence and procedural distress. They help facilitate our patient support groups. They co-facilitate the transition to adult care clinic, and they conduct CF research and QI projects, as well as supervise those and train the psychology interns and externs. The 2 social workers on our team are the lead for caregiver mental health. We administer the caregiver mental health screeners. We do the GAD-7 and the PHQ-9. We also do the EPDS. We had a gap in having 2 social workers at our center, so we've had a little bit of time where we haven't done those, but we're trying to get back on track with that. We provide emotional support regarding diagnosis and ongoing coping with diagnosis, so we're with the physicians at that initial visit, and we follow those new diagnoses through that, until they leave our center, but we see them regularly in those first several months. We facilitate caregiver support groups, and we complete transition readiness within the clinic setting, so that includes the CF RISE curriculum. We co-facilitate those that transitioning to adult care clinic. We participate in QI projects, and we provide education and access to community resources. So some of the strengths and challenges of our team, I want to start with the strengths, is we have a large psychosocial team, which means that we can offer a really robust support to our patient population. We have like dedicated time that we communicate. We also utilize communication through Epic, email, just text messaging, phone calls, whatever we can do, but we do have dedicated time, one time a week, that we sit down and we can round on families. We also collaborate with other disciplines to increase patient wellness. So our psychologists actually do several groups with our physical therapist. We have an ongoing list of patients who might be struggling with body image or need nutritional supports. We assess for food insecurity, and then we also provide intervention for that. So that's how we work with nutrition. Some challenges are role definition. I think this is really common as psychology and social work overlap. Psychologist billing, I put there on there as a challenge. There are times when our families don't want to see psychology because it's another bill, it's another stressor for them, and social work doesn't bill in our hospital, so that's a time when we might shift the way that those responsibilities are. And then staff education. We've worked, since we have such a big team, making sure everyone knows whose role is what and who's the lead on what. That can sometimes be a challenge. So some of the main ways that we collaborate with psychology are these support groups and assisting the patients through the transition to adult care. So I wanted to talk a little bit about the groups that our center offers. One of our psychologists, who's no longer with us, but we love her, is really into acronyms, and so all of these are these crazy acronyms. So Unite to Thrive is talent, health, relationships, inspiration, vision, and empowerment. This group is targeted at the adolescent range. They did like a female-male group, not combined. It was led by psychology and physical therapy, and the interventions included yoga, Pilates, HIIT, strength training, breathing, mindfulness, and acceptance. The next group is for girls. It was 9 to 10-year-olds. It's Courage to Be Me, also a movement group, so movement and empowerment, led by psychology and physical therapy. And this was a space for girls to connect, exercise, build confidence, and learn strategies to thrive. A couple other groups are the Parenting Through Play. This is playful learning adapted to you. I actually came up with that one. Group targeted for toddlers and their parents, led by psychology and physical therapy. So those interventions were like skills for airway clearance, play-based gross motor skills, parenting strategies, and imaginary play. The last group is called our CF Cope group. This is connecting with other parents' experiences. So this group is targeted for parents with babies with CF. We try to stay in the first year of life, but sometimes we expand that depending on how many new diagnoses we've had. So this one is led by psychology and social work. And the goal is to provide a space for parents to connect in the first year of life. So connecting other parents to one another and sharing those experiences and coping with the emotions of that. So social work has had a main role in the COPE group, so I wanted to kind of go into more detail of this group. This is on the left is a handout of the upcoming group that's going to be happening in November. And so we have it split up by week. We do 4 weeks, consecutive weeks. We played around with this. Our first one was like 6 weeks. Our second one was like 4, but every other week. And we just learned that like 4 right in a row just was easier. We had better attendance. So really, we had like a full agenda when we first set this up, and we realized like parents just want a space to talk and connect. So we have like a rough outline of kind of what we talk about, and we have some prompts in case we need to help facilitate conversation, but really we let the parents lead this. So in the first week, we introduce the group, we talk about group expectations, confidentiality. It's just a meet and greet, we introduce staff. And then we provide a space for them to just share, if they're comfortable, their diagnosis story of their child's diagnosis story. And then in the second week, we talk about assembling social supports. So like, who is your support system? How can you utilize them? We talk about talking about CF with others. This is something that our parents have identified as something that's a burden and challenging. And so we want to give them ways to communicate with family members, siblings, daycare. And then week 3, we talk about treatment fears and frustrations. CPT comes up a lot in this group. And then we also talk about hope for the future. We talk about modulators and how exciting it is that these meds are coming out and getting approved for younger ages. And then week 4, we really try to keep it upbeat, and we're talking about celebrating milestones, and we just have some closing discussions, and usually the parents want to exchange information, so we let them. So a couple of the groups that we've done, the parents have remained in contact. So just some of the stats for the COPE group. The first COPE group was held in 2020. 60% of eligible families expressed interest in participating, and then 50% of families who expressed interest in the group attended at least one session. We did have a session with just one family, so they got a social worker and a psychologist session. So the second COPE group was held in 2021. 64% of eligible families expressed interest in participating, and then 44% of families who expressed interest in the group attended at least one session. So anecdotal evidence from the parent support groups have been overwhelmingly positive. Parents reported really appreciating this support group and have continued to connect with each other outside of the group. So another major way that we collaborate with psychology is through our transition to adult care clinic. This clinic was talked about for years before it was actually developed. We played around with a lot of ideas of like having the adult center come to us for like having a physical like clinic where the adult staff came to us, or like we went to the adult center. And what we landed on was a virtual clinic that is actually very simple. It's 15 minutes that the patient is actually involved, but there is some back work that is done by both National Jewish Health and Children's Hospital. So these are just outlining some of the steps that take place. Social work and psychology coordinate the actual clinic. We coordinate with National Jewish on the times that it's going to occur. It's quarterly. And then we identify the patients that are ready to transition. And so we do that, but the next slide kind of talks a little bit about how we know when a patient is ready to transition, but we do it as a team. We do it with our medical providers as well. So then the second step is that National Jewish team and Children's, we meet virtually to round on the patients. So the rounding is actually when the most team members are involved, and it's the Monday before the clinic. And so we try to get the physicians, dietitians, anyone who can participate in the rounds, we want them there to talk about these patients and give a really good handoff to the adult team. And we utilize a letter that I'll share that we complete, and then that's shared through Epic, and we've actually found a way to get the adult team to be able to access that letter in Epic, so there's no faxing involved, which is amazing. So then after these background steps are done, we set up separate virtual appointments for each of our patients. And then in those visits, it's children's social worker and psychologist, and then it's the National Jewish staff. It's usually a social worker and their health navigator and clinic coordinator, but sometimes it fluctuates. But it's a smaller group of people. So I wanted to talk a little bit about when are patients ready to transition. This is something that's come up in our clinic over the years. Like sometimes it feels punitive and we don't want it to feel like, okay, now you need to go. So we're trying to really utilize the CF Rise curriculum and the transition readiness checklist and be talking about transition years before patients transition. So typically our patients are transitioning between the ages of 18 and 22. They've either expressed interest to transition or they've hit some sort of developmental milestone. So there's a pregnancy, a marriage, they've moved away, It's kind of like a natural transition, or they've answered like all of my responsibility on those transition readiness checklists. So there are some barriers to transitioning patients to adult care. We've kept some patients a little bit longer than that age range. One of the biggest reasons is insurance or lack of insurance. We have a really great charity care program at our hospital, and so that can be challenging to send someone to an adult care center where they're going to have some big costs for that care. So also participation in research studies is something that we consider during the transition process. So we might transition someone a little bit later because they want to finish a study. Sometimes they can transition and do the study at the new center. Loss to follow-up is a huge one. This is a huge barrier. We have kids who resurface and then they're in their 20s and they still want to come to children's. So it just that can be a challenge, and we do those case by case. So yeah, and then sometimes transportation or some other resource need can be a barrier in the adult setting. So this was the transfer letter that I was talking about. I think it's going to be really hard for you guys to see, but really it's in the letters. It's a letter template in Epic. For those of you who use Epic, these are really great tools because some of this is just like populated as you open the letter. And so social work completes this with the medical provider. On the bottom, you can see there's a psychosocial section. And so that we're going to put like insurance information, mental health history, education and employment. And we just recently added the like fertility discussion. So if there was a fertility discussion that occurred, we'll put some notes in for that. So this is a really great way to share information like in a quick little like shorter format than sending like a entire CD of records. And so when we round on that Monday before the transition clinic, we review these and they help facilitate the conversation around the patient's medical history. So I had to put a little data in here for our transition clinic. Since starting the clinic in 2021, 61% of eligible patients have participated. It's not a forced participation. Some patients are like, we don't need this appointment, we just want to go, and that is fine. We still do the background work, they just don't do the 15-minute appointment. Some people really value that, and it feels good to like see a staff member and to know where, like we talk about where to park and some other things, so that feels really good for them. So as of October 1st, when I did these slides, we had successfully transitioned 18 patients to NJ, 3 to other care providers, and then 7 are still pending. So we consider our transition to be complete when they attend their first visit at the identified adult care center. 84% of the patients that have participated in the transition to adult care clinic have made their originally scheduled visit. So this is huge. Before we did this clinic, we would like get them scheduled and they would disappear and we'd be like, have they ever been seen at National Jewish yet? And it would be like 6 months and we're calling to try to see. So this has made a huge difference in our transition process. So we're really happy with the success of that clinic. And really, it was developed out of the push to utilize telehealth. We were like I said, we were playing around with these ideas of how to develop a transition clinic. And then COVID happened, and we're like, telehealth was normalized. And we said, why don't we just do a telehealth appointment? When we're looking at how COVID has impacted our supports at Children's, that's a big part of it. In addition to that, we started a lot of these groups. Most of the groups that I talked about are virtual. And then our psychologists are able to provide interventions and they can actually observe. So if they're doing like supports around mealtime, they can actually observe mealtime and like have headphones in the parents and be like coaching them as they're doing mealtime. And so that has been really cool. And the same for treatments. And that is all I have. Thank you.
So we're going to take a couple minutes to do questions and answers. And what I've found interesting as I've been following the questions is a question will pop up on my phone and then it will disappear because the presenter anticipated that question. And so I've looked at questions and then it's gone. Where did that question go? It got answered. So that's been fun.
And I'll invite our speakers back up here so you'll have access to the mic easily for answering questions. Maybe we can stand so they have enough seats.
So I thought I would start with a question that was geared to psychologists. And the question was, are you available for most mental health therapy needs for CF patients, or do you have to refer out? So I didn't know if you wanted to address that.
Sure. For our CF patients, I am fortunately able to be available for most needs. Our model is that our providers will make like a referral to me basically through our system so that we can pre-authorize billing and all of that kind of thing. So most of the time, if a referral is made, I'm able to see that patient, and I do prioritize our CF patients within my caseload too, so that because I have dedicated time for them, so that they don't have to wait too long to be seen.
Thank you. I'm not sure who addressed ADHD. Okay, great. So the question was, why do you think ADHD is more prevalent in patients with CF compared to patients to the regular population?
Yeah, great question. And there's actually just like a few studies that are, that are done and been reported on this. I think this is definitely going to be one of the, subjects that we're going to be talking about more in the future. There are a few hypotheses, right? Part of it is the inflammation hypothesis, right? Because obviously with the CF, right, with the infections and just inflammatory response, right, the pro-inflammatory cytokines that cross the blood-brain barrier affect the brain. And that might be one of the hypotheses. We also know, for example, patients with asthma or other chronic diseases also have an increased risk of ADHD. Another hypothesis is that we know that CFTR gene is expressed in the brain, and we're still kind of learning about its functions. But it is also involved in homeostasis and energy expenditure, and also kind of in some sleep centers. It might affect neuronal maturation, so that might be contributing to development of ADHD. And also but maybe another hypothesis is like just the stress of the chronic illness, right? And just having to manage so many different aspects of one's life. And so the symptoms are more likely to come out and to be identified and present as a problematic. So those are just some hypotheses.
Thank you. This was for Alyssa. Do you have an outpatient child life specialist? And if not, have you considered how they could be integrated, especially since they would be another non-billable service that could also harness the power of play and support typical developmental needs?
We do have outpatient and inpatient child life, but not dedicated specifically to our CF clinic, and so we do refer to them when we can.
So I have one for another psychology question. Do you have a lot of pressure to bill in your role as a psychologist, or is any of your FTE supported by the CF program? I ask because billing can be such a hot topic, good and bad. And so I guess we have a psychologist to answer, but also a lot of folks who have psychologists on their teams too, if you all have any input too.
So billing is a mixed bag. There is an expectation that I bill because my position is very much funded to a certain extent by billing, but I do also have some dedicated funding for CF. So my full pay is covered by some CF funding, some pediatrics department funding, some inpatient consultation funding, so it's kind of a mix. A lot of my caseload is non-CF patients, and so that covers a little bit of my workload too. So I can be a little bit more flexible with CF, though I think the expectation, and this has never been an overtly stated expectation, but I think the expectation is that if I am seeing a patient, I am somehow billing for it. And so if there's not a way to bill for that patient, then we would usually think about how we can cover that need otherwise, or I'm really, really careful about how long I'm in the room for, and will make sure it's a quick enough visit that it doesn't meet threshold criteria for billing. So I do a 15-minute visit so that I can make sure I don't need to bill for it, is kind of how I manage it. There's never been an overt discussion about you're not billing enough. And honestly, there have been discussions of don't worry about it, but there is also an expectation that I am billing at least somewhat. I will always be functioning at a loss, though. I will never make enough money to cover my position. So to a certain extent, the pressure's off on that. So, yeah.
For any of the rest of you who have psychologists in your program, do you have any input on that question? I can maybe also from your psychiatry. Yeah, yeah, absolutely.
Billing is very controversial. I'm sort of like excited to answer, but also, kind of worried, right? So, my position in CF Clinic is covered right now by Stanford Hospital, right? So sort of like my time is protected for coordination and stuff like this. So I tend not to bill, right? Because a lot of the patients that I do see in the clinic, right? Patients that if I were to bill them, like they would go bankrupt, right? So that's why if I'm able to see somebody in psychiatry clinic, right, I'm happy to do that. And also because, I do actually have a really large patient load outside of the CF clinic, the psychiatry, and also I work with inpatient. My RVUs are, over the roof. So nobody looks at that carefully. So, so we continue to be in discussions about this, but I tend not to bill actually in the clinic. And so far it has worked for us, so.
And that's very similar to how my position is as a psychologist. I don't bill in CF clinic because our team's philosophy has been that we want to reduce the burden on patients. But I do bill when in my private practice or my psychiatry clinic. Absolutely, yeah. And it is a really controversial topic. I think I love that these conversations are coming up, and I think it's really great to share those different models and problem solve and even have conversations about how to advocate with upper administration around these things, because it is, unfortunately for psychology and psychiatry, I think a very big push a lot of times to meet those RVU targets. So, solidarity.
Because of the way that I bill, I have to pre-authorize everything mostly, so that does help with some of the unexpected cost piece. I don't do a lot of the random pop-ins to visits because we can't pre-authorize those. So try to avoid unexpected bills in that way, but it does limit the model of how I work a little bit too.
So let's see. We have a question specifically for Elisa for Colorado Children's. What time are the virtual groups when teens and younger children are in school?
I wondered that about your parents group too at 1 o'clock. I was just curious how that affects parents that work.
Yeah. So the children's groups, I'm looking at my psychologist in the back, so I might answer this wrong, but I believe it's often during breaks. So summer break, holiday breaks, or in the after school time frame. And then our COPE group, we try, if we have a significant amount of parents who we have new babies and we're they're all still on maternity leave, we try to do a group then. But we also try to do it around a lunchtime but it's virtual, so often they can take, I don't know, I'm looking at you guys to answer. You guys. But often we've shifted the time before, but it is complicated to try to get a time that works for everyone. So, but we do try to do, the one that's coming up is the 1 to 2 time frame, which works for some people's lunch breaks. But then some of the parents are still on maternity or paternity leave.
Oh, so one quick question. Do you guys admit at the Children's Hospital till 22?
Yes. I think 26 is one of our oldest patients.
No way. Wow. Okay.
Yeah.
When you were we don't transition till 22, I'm where do they get admitted? How does this work?
Right.
Okay.
We still take them.
Wow.
This is a question for Stacy. Do you provide ACT to your patients?
Hi, all. So I personally do not provide it because I do not do actual true psychosocial therapy, but it is something that was provided by our previous psychologist, and obviously something that we will offer when that position is filled again.
I want to throw out to the group if there are any other questions that folks have that they would like to have some answers to. Please speak up. Okay, we got one more.
So, Lisa, I'm going to pick on you again about billing. So with that transition to adult clinic visit, Does that get billed on the pediatric side?
Yeah, so our psychologist does bill. I believe it's just a 15-minute appointment.
Is it considered a mental health bill or under the medical benefit? Because I know, at least in my institution, mental health contracting is different, so that becomes its own unique barrier versus the medical side bill.
I think it's billed under like care coordination. I'm not for sure. I'm just making this up. But I think it's like billed under like care coordination for psychology, not necessarily like a mental health. I think it's billed under the CF diagnosis.
I am going to give one more question I just saw pop up. Have any of you collaborated with community agencies that provide mental health services? If so, how did you train them? I think this is a pretty universal challenge. Like, I know we can't all provide all care to our patients. So when you're kind of liaisoning with the community providers, how do you and do you discuss with them CF?
When we refer to outpatient therapy, we offer to the patient to provide education to their mental health provider. So we ask them, do you want us to have a conversation with them? Do you want us to provide educational resources? And so then we would do an ROI and have a conversation with the provider.
Thank you. I think that's a really important piece of the puzzle. And there are, in different communities, different folks who have that experience, especially if one patient has gone. That's kind of a nice referral stream, but it is really challenging, I think, the first time. So that's a great suggestion.
We also have a therapist with whom we actually closely collaborate in the community, and sort of like, she used to be a social worker who worked at Stanford before, and now we send her additional patients. We're lucky to have a particular grant from CFRI that also sponsors 6 or 8 sessions per year. So this is kind of ongoing collaboration, discussion, and now sort of like she's an expert as well. So like building those personal relationships potentially is also helpful.
I can elaborate on that too. And for those of you who don't know about the CFRI Counseling Support Program, that's open to the national community. So any social worker, psychologist who's working in the United States can get in touch with CFRI and have their patient apply for a counseling grant. It pays for $120 up to 6 sessions with any non-psychiatrist mental health provider in the community. So you can search that up at cfri.org. And then I wanted to also talk about a patient I was working with really acute anxiety. It was white coat anxiety. And the patient just really got frozen when she came to clinic. And she got a community therapist, and she signed an ROI, and that therapist got in touch with me and helped coach me. And I subsequently coached our team around how to manage the CF visit so that the anxiety wasn't made worse. Because I think some of the medical providers can unknowingly contribute to the anxiety by sort of catering to the patient and, oh, it's okay, and just calm down. And actually, it's the opposite. We're supposed to just sort of act normal and more do sort of exposure work. And so the patient actually worked through that and now is much, much better because that therapist was able to work with me.
Thank you so much for sharing that. Did anyone else want to share anything for that question? Okay. I want to just thank you guys all so much for these wonderful presentations, and another round of applause for our presenters. And y'all can have a seat, and we have a few closing remarks, and then we'll let you all head on to your next talks. I want to thank again all of you all for presenting. Oh, you need your mask. There you go. I think it's been such a neat talk to really hear so many different models of care. And and just in terms of a few concluding thoughts here, one of the things I am consistently struck by within CF care is kind of the emphasis on the psychosocial part of wellness. And it's unique. It's not in every field that this emphasis is placed. And I think there's an important consideration really in terms of how our coordination performs a huge service in terms of alleviating some of the impact of social determinants of health as well. we, the whole team can take that lens, but I do think psychosocial providers really do help, ranging from, essential support and liaisoning to services to daily health and wellness, emotional wellness, helping people get into resources, helping manage the stress of living with CF. All of these things have such a huge filter down effect on the medical components of care. I loved hearing the different models of how folks have defined their roles. I think that's a huge piece of this, because every discipline brings its own unique specializations, but there's a huge amount of overlap. So I think that was a really great modeling of how to be really intentional and purposeful about how each person will perform. And sometimes also having that transdisciplinary approach of really taking on other roles. I love that, and being able to kind of step into certain roles that may not be always the traditional piece of what you were trained to do, but serving to help with coverage and also to help, maybe there's a particular patient who feels connected to a certain provider, and being able to be a bit fluid in those roles is also, was very, very striking. I also really appreciated hearing a lot about the communication strategies y'all use. It's remarkable how innovative and creative all of these places and all of y'all's centers have been during especially the pandemic. I think the pandemic has had a lot of bad sides, but one of the things that has brought to us is really this culture of innovation around how we're providing care, and also I think that too has helped in a lot of ways with some of the barriers that patients face in terms of social determinants of health. We're able to access them virtually and maybe even more consistently with that medium. So thank you all for sharing that. I really appreciate too, Dr. Sherrish said that billing, is a controversial topic, but I love the CF community because I think the emphasis is always on patient care instead of billing. There's a lot of creativity around how services are delivered, and the model of the psychosocial care team and that collaboration does allow for that flexibility to occur. If there was one individual provider, that may not be always possible. And so I really love the flexibility and the ability to kind of wax and wane and how that's being addressed. Kind of in closing, I just want to, thank all of you for your great efforts with patients. I think the mental health guidelines came out many years ago now, and I think this set of talks is a real testament to the diversity of different care models that have evolved out of that. Each one of you all has your own unique centers that has really adapted to fit the population that you have, and that's so amazing to see. And I hope each of y'all here in the audience today has been able to take away a few nuggets of things that you may want to bring back to your care center from these amazing talks. So y'all have a wonderful rest of the day. Thank you so much for coming to our session this morning so early, and have a great rest of your conference.